G'day, my name's Tony Lemke. Today we're going to be talking about the challenge of managing multimorbidity. Now, I'm a general practice in Austenville in far north coast New South Wales, which is just in the hinterland above the coast of Ballina, famous for the big prawn that the community there is so proud of. Austenville's also got our favourite big thing representing our major demographic in town, and as you know, that's the giant walking frame main street in Austenville. I've been lucky enough to be a general practitioner in Austenville for the last 25 years, during which time I, like other general practitioners in Australia, have had to become some expertise in the management of multimorbidity, which is the coexistence of two or more chronic conditions in the one patient. Now in this chat today we're going to look at three basic statements about multimorbidity. And the first one is that multimorbidity is common. So we know that the BEACH program in Australia has estimated of those patients attended in general practice in Australia, 2/3 of those patients have at least one chronic condition, and approximately half have two or more. Half of the patients that I see on a daily basis have multimorbidity, more than one chronic condition. Population studies have shown that 1/3 of the people in the population have one chronic condition. The proportion of patients who have multiple chronic conditions rises very significantly with age. An example in the BEACH study, 90% of those patients aged over 80 had two or more chronic conditions. Nearly 30% had 7 or more chronic conditions. If you're in a town like Austenville, 80% of our patients are over 80, so that's a lot of multimorbidity to deal with. So the conclusion is that general practice is a speciality at managing multimorbidity. General practice is a speciality at managing multimorbidity. The most common conditions that we see, you could predict, includes hypertension, diabetes, chronic airways limitation, ischemic heart disease, cerebrovascular disease, chronic and persistent pain, mental health issues, osteoarthritis, and they cluster. And this diagram prepared from Scotland shows some of the ways that the conditions we see are clustered. The incidence of multimorbidity increases as we get older, as we discussed, but also increases with social deprivation, and people with multimorbid conditions are more likely to have mental health issues. Patients with multimorbidity have poorer quality of life, they've got greater loss of physical function, they're prescribed multiple drugs, they're more likely to be admitted to hospital, and they have longer stays in hospital. And there's an enormous expense to the society in that in the Medicare budget in the USA, patients over 65, 80% of all payments are to patients who have multimorbidity, two or more complex conditions. So multimorbidity is common. Statement 2. Multimorbidity is tricky to manage. Why? One reason is because of the evidence we need to manage most conditions is often absent in patients with multiple coexisting conditions. The trials that are done often exclude elderly patients and patients with more than one condition. The guidelines rarely consider comorbidities, and therefore our patients, if we're following a number of different guidelines for a number of different conditions, at risk of polypharmacy and polyspecialists and polyinvestigations and polyinterventions, which is why part of managing multimorbidity is understanding the burden of treatment. And there's a great movement in medicine for Goldilocks treatment, which is where medical care is not too hot, not too cold, but just right. William Osler, the great Canadian physician, said one of the first duties of the physician is to educate the masses, not to take medicine. When our patients with multimorbidity are at high risk of being on multiple medications with multiple adverse reactions, multiple interactions, and high instances of symptoms such as lightheadedness, nausea, muscular aches and pains, changes to bowel habits, dizziness, things that take away from our quality of life. Also, patients diagnosed with many conditions have to make or encouraged to make a number of lifestyle modifications and changes to their diet which they may not find palatable, and often required or recommended to take a number of interventions each day, such as testing and documenting blood sugar. In fact, the burden of treatment for someone just with a diagnosis of diabetes, when measured against quality of life scales, is about the equivalent decrease in quality of life as being diagnosed with a small stroke, just with a diagnosis of diabetes, because of some of this burden of treatment. The other thing that makes multimorbidity tricky to manage is the question of access to multiple specialists and accountability for care. Who's accountable for a patient's overall care when they're seeing a number of different medical specialists? Whose advice should the patients follow? What about all the expense, the inconvenience, and the general waste of time that's involved in seeing a number of providers? Multimorbidity is common. Multimorbidity is tricky to manage. However, statement 3, multimorbidity can be managed. Now, it's been a bit of a weather around here lately. This was the surf at Ballina yesterday. There's me catching that wave. You'll notice that despite the tsunami behind me, I'm looking relaxed and calm. And to manage multimorbidity well in primary care, we need to, like the surfer in this picture, learn to manage the tsunami of multimorbidity with a Zen-like North Coast calm. We know it's our job in primary care. Numerous studies have shown that if we're going to make a difference in chronic disease management, it's not new investigations, new operations, new treatments, new medications, not more specialists. Communities that have the best outcomes in chronic disease management invest in better systems for the delivery of care. So the first way that we look at managing multimorbidity with Zen-like calm is by developing better systems to do that. Systems both within our own practices and systems outside our practice. So the patient-centered medical home is a quality improvement attempt to create systems that support our patients. And we know that the patient-centered medical home is a general practice or Aboriginal medical service that's accountable. A patient chooses to be accountable for their ongoing medical care. And a medical home focuses on 5 key fundamental attributes to improve: person-centeredness, accessibility, comprehensiveness, delivering coordinated care, and focusing on quality and safety. So developing our primary care services to be more medical home-like, using the quality improvement processes inherent in medical homeness, helps us create the systems to manage multimorbidity. One of those systems to identify the value streams from our patients. We measure value from our patient's point of view, and we find it helpful in our practice to identify 3 different patient value streams. The first is the acute care, someone who needs to be seen today because of an acute medical condition. They value getting in on the day when they need it with somebody, but they value being seen at their usual practice. The second value stream is those for routine care, for checkups or for monitoring of chronic conditions, or for preventative health or blood pressure checks. They value being seen by their doctor, their usual provider, their doctor of their choice, the one with they have an ongoing relationship with, at a time that's predetermined ahead of time. They know that on Thursdays they can get a lift in after bingo, so that's the time that they want to have their appointment. So that's the routine care. They value continuity of care at predictable times. And there's a third value stream that we identify in our practice, which is patients with chronic care. These are chronic conditions. These are patients that we want to pull in regularly. We want to see them every 3 months, every 6 months, to make sure that we're being proactive and systematic in managing their care and assisting them to have the best resources and skills and tools they need to look after themselves well. So to do that, we need good systems to identify who our patients are and what they've got. We're in a dairy area here. And so each dairy has a vet attached to it, and they practice herd health. So they know each individual cow in every herd. They measure all sorts of parameters, including obviously their milk production, but also their breeding cycles and the amount of food that they eat, and their time, their growth rates, They also look at the herds as a whole, because sometimes an entire herd's breeding pattern will be down or milk production will be down. They can identify problems in the herd, in trace elements in the soil or other things affecting their community or their herd as a whole. And as an industry, the dairies around here get together to look at how they can improve their ability to care for their herds, their individual cows, their herds as a whole, cooperating together in the cooperative, which is Norco, to better produce outcomes for the entire area. So we need to develop systems to understand who our patients are and what they've got, and to look at them in a population health way. Number one, better systems for herd health. Number two, managing multimorbidity is a team sport, including the patient, but will often involve a number of other providers, both specialist providers, pharmacies, allied health, and people in special roles of behaviouralists, exercise physiologists, diabetic educators, dietitians, and people within our own medical home, nurses working in the role of care managers and other general practitioners in our practice. So we want to have tools to develop informational consistency with a common understanding of the rules of the team sport, or the rules of the game, the goals of each patient and the roles of every member of the team. And there are tools that have developed, such as My Health Record, patient-held care plans, online shared care planning tools. But the most important thing about developing better teams is a matter of culture. So we talked about, well, there is a model of integrated care teams in the person-centered health system where patients have an ongoing relationship with a particular practitioner over time, supported by their local medical home team, their primary care team, and the rest of the health service wraps around that relationship to provide the care when and if required, so that patients can access the care team that they need, that care team is of high quality, and they experience care as being joined up. To create solid integrated care teams that all understand the rules of the games and the goals of each individual patient and their own roles, and that they have informational consistency, requires everyone to identify their three jobs. So in quality improvement circles, we often say that all of our health providers have two jobs. Number one is to do the work, which is see the patient in front of you, deal with all their particular issues and problems. This is the role we're very comfortable with as healthcare providers, one we're familiar with, one we do all the time. The second role, which is done less well in healthcare, is to improve the work, which means to look at the systems where I'm delivering the care, so the next time that patient comes in, or the next patient who comes in, I can do my work better. That's a quality improvement. How can I develop my skills and resources and tools to do the work better? How can I improve the work? And the third job, or one we think about even less, is to work the team. So when I'm seeing this patient in front of me, what do I need to do to make sure that the other members of this patient's integrated care team have the resources and the understanding and the knowledge and the information they need to make good decisions for this patient? How can I make sure that all the other members of this patient's care team have are able to do their three jobs well? That's my third job. And unless we can identify the members of a patient's integrated care team, who's their pharmacist, who's their dentist, what allied health people are they seeing, which specialists are they seeing, which psychologists are they seeing, who are they seeing in the community, who's caring for them at home, who's their carers at home. Unless then I can identify the members of the integrated care team, I can't work the team and I can't help them do their three jobs. So we need to work the team. And the next part of Zen-like multimorbidity management is to practice person-centered care, to work with our patients, the greatest untapped resources in healthcare, to make sure they have the skills that they need to look after themselves at home. They're empowered through information and resources and things like sick day action plans and care plans with clear goals and activities to undertake, so the carers are well informed about their state of health and what needs to be done. We are not going to manage multimorbidity well unless we empower our patients to do that. And to do that, we have to understand each patient's individual circumstances and story. Again, William Osler, the Canadian physician we quoted before, said it's much more important to know what sort of patient has a disease than what sort of a disease a patient has. And then multimorbidity, where the guidelines can be unclear, where the trials don't identify exactly what we should do given the patient's circumstances. The path through that is that of shared decision making, with our patients where they're capable, explaining the circumstances of their health, what medications and other treatments are available, what the efficacy and efficiency of those is, the likelihood that they'll be helped by taking a different medication or new medication, and allowing our patients to choose. Given this information, what would you like to do? Sometimes they choose, doc, it's up to you. Other times I say, looking at, for instance, taking a statin, realizing that their risk goes down from 93% risk, a 10-year absence of heart attack or stroke, down to 89%, they'll say, I'm not taking that medication for that percentage change in risk. Other people will be mad keen to take the medication. We need to have the tools to present to our patients to help them identify what interventions are available to them and what effect that is likely to have on both their health and their risk of having further events. Skills in shared decision making are paramount to good management of multimorbidity, particularly in the absence of guidelines that can help us given the plethora of diseases, and can certainly, with the support of the patients, decrease the polypharmacy, polyintervention, polyspecialist, polyinvestigation pathway. Now there's a certain role for care managers in the management of many people with multimorbidity. Some 20% of patients don't have the capacity to manage their own care well and require the support. Care managers are not a panacea for the culture of understanding our three jobs, of working together. A lot of the time, if we choose to demand the best from our fellow providers, the fellow members of our patients' care team, if we go out of our way to make sure that communication between all team members is good, that we improve the accessibility of our services and the information the patients hold about what they're meant to do, some of the problems that a care manager is meant to solve fall away. So the need for case managers for patients can be a sign of a failed system and a failed culture. Having said that, nurses acting the role of care managers within my general practice has been a necessary part of allowing me to manage complex patients with multimorbidity well, and we couldn't do without them. I think they're a critical and important member of a medical home team. Care managers can be situated, as I'm describing there, within a general practice. They can be situated as disease-specific case managers. As a diabetes manager at a local hospital, there is also a renal nurse and as a cardiac failure nurse. Many of our patients, of course, have all three, which is complicated, but you can have disease-specific care managers or chronic care managers. You can also have more generalist care managers based in the community or based in the hospital. In my experience, wherever we can, by supporting case management as part of that core role of the primary care team, gets us best bang for our buck. And the use of case managers where that's not possible can be important for many patients. A particular issue that we find is for patients with really complex mental health issues, with schizophrenia and psychosis and mania, that this is a particular role for specialist care manager skills. One of the functions of a care manager is care coordination, particularly for those patients, like those we've been discussing, those 20% of patients who are unable to self-manage. This is aimed at achieving a smooth progression of care from the patient's point of view and includes arranging external services and consultations, timely communication, facilitating logistical arrangements for patients. So a care coordinator needs a knowledge of local resources and formation of relationships with both the patient and with a range of providers. So some other roles of a care manager include developing, maintaining and managing disease registers for patients with particular chronic diseases to ensure they receive best practice care, developing systems to identify patients at risk of chronic diseases, improving patient self-management skills with motivational interviewing and goal setting, developing and implementing cycles of care for varying conditions, ensuring recall and follow-up, identifying changes in a patient's condition that may require non-routine review by the patient's usual GP, managing quality improvement processes and ensuring there's data to drive improvement, and ensuring and improving the clinical data quality we hold about patients. This therefore is a very important role in managing multimorbidity with Zen. So we need to structure our practices to support good use of care managers so that the patients experience a team of three. the general practitioner longitudinal care over time, the care manager also longitudinal care over time, and the patients and their families themselves. So the final way of managing multimorbidity is to make sure that we take that person-centered approach, which means what can I do in this encounter with my patient, what can I do to intervene to make it easier for my patient to change what they do with their hands, feet and mouth to create a richer, more meaningful life for themselves. The bottom line is how can I help my patient today to have a richer, more meaningful life? What changes can I help them to make that will help them to achieve that? So the lessons about multimorbidity. Multimorbidity is common. General practice is a speciality for managing multimorbidity. Managing multimorbidity can be tricky. We need to ride the tsunami of illness that's coming our way and maintain our zen by using better systems, by developing our teams, and by maintaining a person-centered approach. Thank you.